Good evening and welcome to this webinar on Sglt2 inhibitors and GLP-1 receptor agonist, cardiorenal metabolic drugs for the ages. I'm Professor Ralph DeFronzo and I'm Chief of the Diabetes Division at the University of Texas Health Science Center here in San Antonio. In the next 15 to 20 minutes, I'm going to take you through really some amazing breakthroughs have come with the use of these two classes of drugs, which really have revolutionized our treatment of patients with type 2 diabetes. Because now we have medications that not only will lower the blood sugar level and prevent the microvascular complications, but also will prevent the macrovascular complications. It's really an exciting time now to be in the field of type 2 diabetes. So let's get started. And let's start with the SGLT2 inhibitors. And I'm going to discuss three aspects of the SGLT2 inhibitors. Let's start with the metabolic benefits of this class of drugs. As some of you who are listening in may know, I invented the SGLT2 class of drugs. And we were the first to demonstrate that people with type 2 diabetes have an elevated threshold for spilling glucose in the urine. So when you and I, our threshold for spilling glucose into the urine is a plasma glucose concentration of about 180 milligram per deciliter. But in people with type 2 diabetes, that threshold increases markedly, and it increases in proportion to the level of glycemic control. So in people who have a hemoglobin A1C that's 8 to 9, the threshold may be as high as 240, 250 milligram per deciliter. The SGLT2 inhibitors lower that threshold, and in doing so, allow the glucose to come out in the urine. And as the blood sugar now starts to drop, we reverse what we call glucotoxicity. So elevated glucose levels poison your beta cell, they inhibit insulin secretion, and they also cause insulin resistance. So now, as the blood sugar level comes down, we're going to improve beta cell function and we're going to improve insulin sensitivity. In our original studies, we showed that insulin sensitivity improved by about 35 to 40%, and beta cell function improved by 98%. So these improvements in these pathophysiologic defects are going to lead to a nice reduction in the hemoglobin A1C. Now, because we're also losing calories in the urine, our people are going to lose weight. That's very good because obesity is an insulin-resistant state. And as you become more sensitive to the insulin, you take the stress off your beta cells and you will preserve beta cell function. We also know, because these drugs work on the kidney, that's a very different mechanism of action than all the other drugs that are currently available. So we can use these drugs in combination with any other approved drug for the treatment of our diabetic patients. Because these drugs block not only glucose reabsorption, but sodium reabsorption, we get nice drops in blood pressure, about 5 to 6 systolic and 1 to 2 diastolic. And very importantly, these drugs do not cause hypoglycemia, which makes them very easy for people to use, whether you're a primary care physician, whether you're an internal medicine doctor, whether you're a cardiologist, an endocrinologist, or a nephrologist. Now, because these drugs improve a number of cardiovascular risk factors, one might also predict that these drugs would give cardiovascular protection. And in fact, we now have a large number of cardiovascular outcome trials demonstrating that the SGLT2 inhibitors can decrease the MACE endpoint. We'll come back to this in a second, and can decrease hospitalization for heart failure. So let me first address the issue of cardiovascular disease and type 2 diabetes. So when you see a newly diagnosed type 2 diabetic patient, over 2/3 of them already have subclinical cardiovascular disease, and another 15 to 20% have clinically manifest cardiovascular disease. And as I think most of you are aware, the great majority of the mortality, some 70 to 80%, in our type 2 diabetic patients is attributable to cardiovascular disease. And we know that the cardiovascular disease manifests itself some 15 years earlier in people with type 2 diabetes than in non-diabetic individuals. Now, as our diabetic population is living longer, we're seeing a lot more heart failure. And heart failure has increased some 2 to 3-fold in our diabetic patients. And if you have a diabetic patient with kidney disease, the cardiovascular mortality increases even further, some threefold. So when you're taking care of diabetic patients, you have to focus, of course, not only controlling the glucose, but also in intervening with medications that are going to prevent these cardiovascular complications. So the very first study showing the benefit of this class of drugs was done with empagliflozin, and this is the EMPA-REG outcome study. And as we read from left to right, you can see the MACE endpoint, and MACE stands for Major Adverse Cardiovascular Events, and there's a triad of them. It's non-fatal MI, non-fatal stroke, and cardiovascular mortality. It was decreased by 14%. So the hazard ratio was 0.86, highly statistically significant. If you look in the middle and you look at the effect of empagliflozin on cardiovascular mortality, you see this dramatic 38% decrease, a hazard ratio 0.62, highly statistically significant. And if you look at hospitalization for heart failure, again, a very dramatic decrease. And the other thing I want to point out is if you look here on the time schedule, you can see that these benefits on mortality and in hospitalization for heart failure are seen within the first 3 months of therapy. Now, I'm not going to take you through every individual cardiovascular outcome trial that have been carried out with the Sglt2 inhibitors. Instead, what I've done here at this slide is I've summarized for you these results on one slide. So the EMPA-REG outcome study is shown in purple. The DECLARE study with dapagliflozin is shown in yellow, and the CANVAS study with canagliflozin is shown in green. You can see all three decreased the MACE outcome. If you look at cardiovascular death, it might appear that there's a difference between these drugs. But what I'm going to take you through is that it's most likely that the differences that we see in cardiovascular mortality are more related to the patient population than the drug itself. So if you look at the EMPA-REG outcome study here in purple, as I showed you, there's about a 40% decrease in cardiovascular death. This is exactly what you would expect, because in the EMPA-REG outcome study, 100% of the people who got into the study got in because they had had a previous cardiovascular event. So they're the sickest people. So they're most likely to benefit in terms of cardiovascular mortality. If you look at the DECLARE study, which is in yellow, this was the least sick population, with 2/3 of the people getting in because they had risk factors and not because they had a cardiovascular event. So you can see they really didn't benefit much in terms of mortality. And you can see with the canagliflozin, intermediate in terms of risk. 2/3 of them had a previous event, and you can see an intermediate reduction in cardiovascular mortality. If you look at non-fatal MI, all three similarly decreased non-fatal MI. If you look at non-fatal stroke, this was a surprising finding to us because these drugs dropped the blood pressure quite significantly, yet we did not see a benefit in terms of stroke, and we still really do not understand why we didn't see this benefit. If we look at hospitalization for heart failure and improvement in myocardial function, you can see all three of these drugs, dramatic effect, hazard ratios about 0.7. And then even more dramatic is this marked reduction in the renal composite outcome, which we'll come back to in a minute, with a hazard ratio of about 0.55 to 6. So these drugs are very powerful in reducing cardiovascular events and in preventing progression to renal disease. Now, there also have been now two big studies, one with dapagliflozin and one with empagliflozin, in terms of prevention of heart failure. And the results are really quite similar. I'm going to show you the dapagliflozin data. So here, these are people with heart failure and reduced ejection fraction. And we look at the primary composite endpoint, which is hospitalization for heart failure, cardiovascular death, and emergency room visits for heart failure. Most of these people had class 2-3, New York Heart Association heart failure. Now, if we look to the left in the panel, the primary outcome, You can see here, hazard ratio is 0.74, highly statistically significant reduction. In the middle, hospitalization for heart failure significantly decreased. And very importantly, to the right, cardiovascular death significantly decreased. Now, the important thing in this study is that it included both people with diabetes and non-diabetes. So these SGLT2 inhibitor drugs work not only in the diabetic population in preventing heart failure and cardiovascular mortality, but also in the non-diabetic population as well. Let's now turn our attention to the GLP-1 receptor agonist. This class of drugs effectively reduces the A1C, and they do so because they have a very powerful effect to preserve beta cell function. In fact, the only other class of drugs which has such a powerful effect are the TZDs, namely pioglitazone. These drugs inhibit glucagon secretion. They're excellent drugs in promoting weight loss. I'm not going to be able to go through the pathophysiology of type 2 diabetes with you because we have a limited amount of time. But there are 8 major pathophysiologic disturbances, and 6 of those disturbances are corrected by the GLP-1 receptor agonist. So as we said with the very first bullet point, these drugs are very good drugs at lowering the A1C. And like the SGLT2 inhibitors, they do not cause hypoglycemia, and they have an excellent safety profile. Now, what we've also learned is that these drugs are very good in terms of decreasing cardiovascular events. So there have been 4 big trials. I've summarized them here for you on one slide. So reading from left to right is liraglutide in the LEADER study, 13% reduction in the MACE endpoint. Semaglutide in the SUSTAIN-6 study, a 26% reduction in the MACE endpoint. With exenatide bidurium, you can see that the hazard ratio of 0.91 did not quite reach statistical significance, p-value 0.06. But in this study, there was a large drop-in of SGLT2 inhibitors in the placebo group. And if you were to reanalyze the data, removing the SGLT2 inhibitors, you would find that this was highly statistically significant. And to the far right, we have dulaglutide in the REWIND study. Again, a very similar reduction in the hazard ratio. Now, the important thing about dulaglutide in the REWIND study is that people who had had a previous cardiovascular event, as well as people who had risk factors without a cardiovascular event, all benefited from the MACE endpoint. So it's telling us we should be using these drugs much earlier in the natural history of type 2 diabetes before people have a cardiovascular event. Now, let's look at kidney disease, and let's start with the SGLT2 inhibitors. Now, in all of the big cardiovascular outcome trials, there was a renal endpoint, which was worsening renal failure, end-stage renal disease, or progression to dialysis or to transplantation. And unfortunately, in the cardiovascular outcome trials, these were secondary endpoints. So the FDA does not give approval for secondary endpoint. But let me take you through these secondary endpoints before I get to the trials which had renal disease as the primary endpoint. So let's start here at the top. There were some people who had established cardiovascular disease in all of the trials. So EMPHA-REG, as I told you, 100% of the people had a cardiovascular event. CANVAS, 2/3 did not have a cardiovascular, 2/3 did have a cardiovascular event, and in DECLARE, 2/3 did not have a cardiovascular event. And if we look at this composite renal outcome, you can see all the points fall to the left of the hazard ratio of 1 with a mean value of 0.56, meaning a very impressive 46% reduction in this composite renal outcome. Now, if we look at the 2 studies in which people got in because they had risk factors, they're CANVAS and DECLARE. Again, if you go to the right, points are to the left of the identity line of 1, hazard ratio is 0.54, meaning there's a 46% reduction in this composite renal outcome. But as I mentioned to you, the FDA does not give approval for secondary outcomes. But there have been two. The first one was credence, in which the composite renal outcome was very similar to the one that I just reviewed with you. You can see here a hazard ratio of 0.66, 34% decrease in progression to end-stage renal disease, dialysis, transplantation, doubling of your serum creatinine, or 40% reduction in GFR. The curves separate here at about 1 year. They continue to separate, and very highly statistically significant difference in the people treated with canagliflozin. Now, let's look at DAPA-CKD. Very similar, in fact, even more robust results with a hazard ratio of 0.56. But the important point of DAPA-CKD is that 55% of the people in DAPA-CKD had non-diabetic renal disease. So what this is telling us is that the mechanisms that cause progressive renal disease are very similar in people with diabetes and non-diabetes, and they're similarly affected by the Sglt2 inhibitors. Now, let's take a look at the kidney in terms of the mechanisms that contribute to the kidney disease. So when I gave the Banting lecture at the American Diabetes Association, I called it From the Triumvirate to the Ominous Octet, a new paradigm for the treatment of type 2 diabetes. And I outlined the 8 pathophysiologic defects responsible for hyperglycemia in people with type 2 diabetes. Well, it turns out there's an ominous octet for diabetic nephropathy as well. So let's take a quick look at this. Of course, if you control the blood sugar, you're not going to develop diabetic kidney disease. So the most important thing that we can do in our diabetic patients is make sure that the hemoglobin A1C is less than 6.5. We know that the single most important factor that accelerates the decline in renal function is hypertension. So we need to maintain meticulous blood pressure control. That means less than 120/80. We also know that there's deranged tubulo-glomerular feedback. The Sglt2 inhibitors correct this defect at the level of the kidney. We know that because of this heavy reabsorption of glucose in sodium and the proximal tubule, that sodium that's in the proximal tubule needs to be pumped out by the sodium-potassium ATPase pump. That requires energy, and that requires oxygen, and the kidney is hypoxic, leading to reactive oxygen species stress, inflammation, fibrosis. Those podocytes, with their foot processes, form the barrier that prevents albumin from getting in the urine, are injured in people with diabetes. That lets albumin leak into the urine, and albumin is very toxic to the kidney. We also know that most of our diabetic patients are overweight, and this is lipotoxicity. So fat in muscle causes insulin resistance, fat in liver causes NASH and insulin resistance, fat in your arteries causes coronary artery disease, fat in your glomeruli and mesangial cells and tubule cells it plays a very important role in the development of diabetic kidney disease, and Sglt2 inhibitors are very good at mobilizing fat out of the kidney. We also know that there's tubular hypertrophy with release of growth factors, which increase the intraglomerular pressure. And then lastly, there's a genetic component, which we don't really understand. And we have lots of thoughts about some genes that are involved, but we have yet to identify those which are the real culprits. Now, what about the Sglt2 inhibitors? You can see by the stars, they correct 6 of the 8 problems. So they are going to be excellent drugs for the prevention of diabetic nephropathy. Now, if we have 8 different pathophysiologic disturbances that contribute to the diabetic nephropathy, it's obvious that we're going to need multiple medications to slow or halt the progression of the renal disease. So we've had the ACEs and ARBs, but despite the fact that we've had the ACEs and ARBs, and they are good drugs, there's still a very high incidence of progressive renal disease. We now have the Sglt2 inhibitors, and the Sglt2 inhibitors, all the studies were carried out in people who were taking ACEs and ARBs. So we know that we're going to get an additive effect here. We now more recently have had a mineralocorticoid receptor agonist, a non-steroidal one, feninerone, the Fidelio study, recently published in the New England Journal of Medicine, which shows both renal and cardioprotective effects, which can be added to the ACEs, ARBs, and SGLT2 inhibitors. And although we don't have a definitive study, I'm going to come back to this in a second, there also is evidence the GLP-1 receptor agonist also may be playing a very important role in renal protection. So here now is the Fidelity study. If you look to the left, this is the renal composite outcome, which is end-stage renal disease, dialysis, transplantation, reduction in GFR to less than 15, or a decrease of greater than 40% in renal death. Hazard ratio for renal protection of this composite outcome, 0.82, highly statistically significant. Again, you see the curves start to separate out here at about a year. If we look now at the key secondary outcome, which was a cardiovascular one, so this is cardiovascular death, the MACE endpoint, hospitalization for heart failure, hazard ratio 0.76. So you see here we have now another drug like the Sglt2 inhibitors, which gives us not only renal protection, but cardiovascular protection. And although this drug has yet to be approved by the Food and Drug Administration in the US, I'm quite confident that it eventually will be approved, then giving us at least 3 drugs. Now, what about the GLP-1 receptor agonists and their effect on the renal composite outcome? There have been 5 trials, and I've shown them to the left: Elixir, Leader, Sustain, 6, Excel, Rewind, all showing a reduction in this renal composite outcome. But in this renal composite outcome was included proteinuria. And proteinuria, albuminuria, is really not such a great indicator of renal disease. So this meta-analysis was done with proteinuria. It is highly statistically significant, hazard ratio 0.83, p-value less than 0.001. But now what happens if we take out proteinuria and we repeat the meta-analysis? You can see in 2 of the studies, the points fall to the right of the hazard ratio line of 1. And the mean hazard ratio is 0.87, and it's borderline statistically significant. So we don't have a definitive answer yet about the GLP-1 receptor agonists and their protective effect on the progression of renal disease in people with type 2 diabetes. But we do have the FLOW study that's being conducted by Novo Nordisk, and we'll have to see what the results of this show. So what can we conclude about the Sglt2 inhibitor and the GLP-1 receptor agonist? These drugs are exceptionally effective in lowering the A1C. They lower the blood pressure, they promote weight loss, and they don't cause hypoglycemia, and they can be used in combination. And this is a great combination therapy for our diabetic patients. And not only can they be used in combination with each other, they can be used in combination with all other anti-diabetic agents. They, very importantly, both classes of drugs reduce the MACE endpoint in type 2 diabetic individuals who are at high risk or who've had a previous cardiovascular event, and they slow or prevent the progression of diabetic and, importantly, non-diabetic kidney disease. So in my opinion, these 2 classes of drugs should be considered as first-line therapy in all type 2 diabetic patients. And in fact, I favor them, both of these classes of drugs over metformin, and I favor institution of therapy with combination of both the Sglt2 inhibitor and GLP-1 receptor agonist. My other 2 favorite drugs are pioglitazone and metformin, and in actuality, I always start my patients on triple therapy. And I know that sounds somewhat aggressive, but I can tell you the EDIC study is now published, the 3-year data, and the 6-year data are being written up. And in the EDIC study, we showed really quite dramatic benefits using a combination of a GLP-1 receptor agonist and metformin and pioglitazone. At the time EDIC was initiated, We didn't have an SGLT2 inhibitor, but I think that actually would probably be better than even metformin. So I hope this was informative and provocative, and I look forward to the question and answer period, which is coming up. Thank you very much for your attention.